Namaste and good morning. I'm Dr. Leison Maharjan. I'm an ENT and hair and neck surgeon. Currently, I'm working as an otolaryngologist, hair and neck surgeon at Pott Academy of Health Sciences as a lecturer. And today we are going to discuss about CEE recall questions on ENT and hair and neck surgery. So now we are going to talk about the first question. The question is, which of the following best describes Pott's Puffy tumor? There are 4 answers: tumor of the frontal bone, tumor of the lacrimal bone, osteomyelitis of the frontal bone, osteomyelitis of the lacrimal bone. The students usually get confused with the term tumor out here, but actually this word tumor is a misnomer. So let's see what is this Pott's Puffy tumor in the next slide. So Pott's Puffy tumor is a misnomer, and we can usually see this Pott's Puffy tumor as a complication of frontal sinusitis. It is a subperiosteal cellulitis or the abscess. We can see the collection in the frontal bone out here in the MRI, and this term was first described by Sir Percival Pott in 1768. And the osteomyelitis of the lacrimal bone and the tumor of the lacrimal bone is really rare, so we can rule out this. And also, as this is the osteomyelitis, we can easily rule out the tumor of the frontal bone. So the answer would be osteomyelitis of the frontal bone. So from this question, we can make some other questions as well. For example, the questioner can ask, what is the most common tumor of the cranial wall facial skeleton? And the answer would be osteoma. And the another question that we can make is, in which sinus is the osteomas very common? The answer again would be the frontal sinus. So from this single question, we can make various questions. So now we are going to discuss about the second question, and this is about the semicircular canal. The question says, semicircular canals are responsible for which of the following movement? So there are 4 options: angulatory, vertical, horizontal, and linear. So to understand this question, we have to know about the physiology and anatomy of the inner ear. So let's see. Now we can see in the picture here. So this is the vestibular auditory system. Cochlea is responsible for the hearing, whereas this vestibular system is responsible for the balance. And we have got these 3 semicircular canals: superior, posterior, and lateral canals. And we have got 2 otolith organs, tracheal and utricle. So these 5 organs helps to detect the motion in 5 different direction, or the 5 different either linear or the angulatory motions. So let's see what are their functions. So first, the otolith organs, they are responsible for the linear motion, whereas the semicircular canal is responsible for the rotational motion. So going back to our question, this linear is ruled out because otolith organs are responsible for this linear motion, and in the linear motion, utricle is responsible for the horizontal acceleration, and cycle is responsible for the vertical acceleration. So that rules out our option number B and option number C. So semicircular canal is responsible for the rotational or the angular movement. So our answer is A. Now in the semicircular canal, there can be other various questions which can be made from these questions. For example, in the superior semicircular canal, this is responsible for the yes kind of movement, and this posterior is responsible for the lateral flexion movement, and this horizontal canal or the lateral canal is responsible for the no kind of movement, this movement. Now the third question: a patient presented with parotitis and is on broad spectrum antibiotic for 2 weeks, but the patient's condition is still not improved. So what is the most probable cause in this case? So whenever we see this kind of question, like which asks most probable or the most likely, most appropriate question, we have to be very careful, because out of these 4 questions, there can be more than one appropriate answer, and we have to choose among those answers. So we have to read all these answers properly. So now let's see the options: tubercular parotitis, Sjogren syndrome, fungal parotitis, and allergic parotitis. So tuberculosis is really common in our part of the world, and usually tuberculosis does not respond to antibiotic; it only responds to anti-tubercular treatment. So let's keep this option. Now the Sjogren syndrome, it is usually seen in the females, and it is usually accompanied with xerostomia or the dry mouth, uh, xerophthalmia or the dry eyes, and also associated with the other symptoms such as arthralgia and myalgia. So whenever the examiner keeps the options as a Sjogren syndrome, he or she usually gives hints about the patient is female or more than 40 years of age and has got the symptoms such as dry eyes and dry mouths, etc. And this fungal parotitis is really rare condition, and even the allergic parotitis is really rare. So among this, the question says, what is the most probable? Possibilities are all, but the answer is tuberculosis. Now the fourth question, which is the most common organism to cause acute epiglottitis? Whenever there are questions such as the most common organism asked, we can be confused because more than one organism can be responsible for the disease, but we have to choose which is the most prevalent one. The options are Staphylococcus, Haemophilus influenza, Pseudomonas, and Parainfluenza. So among these four, Haemophilus is the most common one. The answer in this question is quite straightforward. But we can see in the literature that other bacteria can also be the causative agent for this condition, such as Streptococcus pneumoniae, Staphylococcus aureus, and beta hemolyticus streptococci. And there are so many questions that can be made out of this chapter. This is a very important chapter from exam point of view, such as Haemophilus influenza can cause meningitis, it can cause otitis media, it can cause sinusitis, epiglottitis, brachybronchitis, bacteremia, and pneumonia as well. And there are other questions such as what are the common signs that can be seen in this epiglottitis? The answer would be thumb or the thumbprint sign that can be seen in the X-ray out here. This is the swollen epiglottis. This can be seen in the endoscopic picture here. So these are all the swollen epiglottis, which is responsible for the thumbprint sign in the X-ray. The another sign which is very commonly seen in this condition is vallecular sign. That means the obliteration of the vallecula in the X-ray. So these two signs are very important signs that can be seen in acute epiglottitis. And in this chapter also comes the group versus epiglottitis. So there is a table, and we can see in the table that viruses are very common causative agent for the group, such as the parainfluenza virus. So this is responsible for the group. RSV virus, enterovirus, whereas H influenza is commonest for the epiglottitis. So other questions that can be made from these chapters are the usually whenever there is some question made from the epiglottitis, usually it is described as a patient having stridor, patient being toxic, and patient in distress, and 3Ds: drooling, dysphagia, and dysphonia. So these kind of hints we have to be very careful in the questions. Whenever we see this kind of hints in the question, then answer is usually epiglottitis. And the patients with croup usually have barking cough, stridor, and they are usually non-toxic and usually fever less than 39 degree. And as for the signs, steeple sign usually seen in the croup, whereas this thumbprint sign I have already explained, and along with the vallecular sign is seen in the epiglottitis. Now the fifth question, which of the following is the earliest presentation of the glottic carcinoma? Actually, all these four symptoms like hoarseness, stridor, cervical lymphadenopathy, and shortness of breath can be a presentation of the glottic carcinoma depending upon the whether the patient presents early or the late, but we have to choose the earliest presentation. Next, go to the another slide. As we can see in the picture here, so this is a true vocal cord, and there is a mass. So even this small mass can hamper the vocal cord function. So that can cause the hoarseness, and it is the early sign of glottic carcinoma. So answer is A. So, so now the larynx can be divided into the three parts: supraglottis, glottis, and subglottis. So from the laryngeal inlet up to the true vocal cord is the supraglottis, true vocal cord, and 1 centimeter below is glottis, and below that up to the lower border of the cricoid is subglottis. So there are several questions that can be made from these questions, such as just like this question, which of the following is the earliest presentation of the supraglottis carcinoma? So in that case, the answer would be dysphagia, odynophagia, or otalgia. So these are the early presentation of the supraglottic carcinoma. Similarly, the question can be which of the following is the earliest presentation of the subglottic carcinoma? In that case, shortness of breath and stridor is the answer. So the shortness of breath and the stridor is the early presentation of the subglottic cancer. And as for the cervical lymphadenopathy, as vocal cord has got no lymphatics, usually cervical lymphadenopathy is not the early presentation. However, in the late presentation, when this tumor goes in the supraglottis or the subglottis, it can get into the lymphatics, and cervical lymphadenopathy can be present as a late presentation. So the answer is hoarseness of voice. The sixth question: a child presented with ASOM or the acute suppurative otitis media is prescribed antibiotic for 14 days and other medication for symptomatic relief. Pain subsided, but hearing loss is still persistent. That means the medicine is not working properly. On otoscopic examination, eardrum is bulging. So all these are the signs of acute otitis media. So what is the most appropriate management in this case? So whenever we see these words like most appropriate or the most common, more than one answer can be true, but we have to find out the most appropriate. So we have to read the options properly. So our options are change the antibiotic, continue same antibiotic for further seven days, myringotomy, which is to make an incision in the tympanic membrane to drain the fluid, and answer number D is give antihistamine only. So from these options, we can clearly rule out answer number B, because there is no point using the same antibiotic for 7 more days when it is not properly working for 14 days. So giving antihistamine only is not an appropriate option, because antibiotic is not working and there are chances that patient might go into the complication because hearing loss is already present there. So we have got two options now. Answer is either A or answer is either C. So we have to choose between these two options. So now let's see. Myringotomy is an incision that is made in the tympanic membrane, like shown in this picture. So by doing the myringotomy, we can decompress the pus which is collected in the middle ear cavity. And the another advantage is we can take out the pus and send the pus for the microbiology or the culture sensitivity test to identify the antibiotic that can work with the causative agent. So this is the additional advantage. And also if there is any impending complication that can occur with the acute otitis media, it can be prevented by the myringotomy. So the most appropriate answer for these options are answer number C would be the most appropriate. So there are other questions that can be made from this question as well. Like we can see in this picture in the right hand side, we can make a curvilinear incision in case of acute otitis media in the tympanic membrane, and we can make a linear incision or the radial incision in case we have to insert the grommet for the acute for the otitis media with effusion. So the question can be, what type of incision would you make in the tympanic membrane? The answer would be circumferential or the curvilinear in case of acute otitis media, radial incision in case of serious otitis media or otitis media with effusion. Now the seventh question: a patient with obstructive sleep apnea developed an apneic event with development of cyanosis during sleep. At that time, his SpO2 level is measured to be 78%. His apnea-hypopnea index was 47. What is the first step that you would take for the management of this case? So we have got four options here: CPPV or continuous positive pressure ventilation, endotracheal intubation, oxygen therapy, palato-pharyngoplasty. So in this case, we have to be very careful that it's a case of obstructive sleep apnea, and SpO2 is severely decreased 78%, and this AHI index or apnea-hypopnea index is 47. So that means we can see in the picture here, AHI score can be divided into 3 groups: mild, moderate, and severe. So AHI score more than 30 is considered to be severe. So in our case, it is 47. So it is a case of a severe sleep apnea. So what are the first steps that you would take? So in this case, usually this endotracheal intubation is usually done in the cases of this acute obstructive airway disease, and usually this surgery would not be our first choice, because whenever we should treat the patient, we should always go conservatively first, and then only if the conservative won't work, then we would go to these surgical options. So let's see. So our options are CPPP and oxygen therapy. And as the obstruction is very severe, we have to open up the airway, and for that we need positive pressure ventilation along with oxygen therapy. So our appropriate answer would be answer number A. Now let's see. Severe OSAS, CPPP is a gold standard for it. Endotracheal intubation and oxygen therapy would not be an appropriate option in this case, and surgery would always be chosen if CPPP fails. And you can also read about the apnea and hypopnea in this chart. And apnea-hypopnea index is calculated by counting the number of apneas and hypopnea for total sleep time. Now the question number 8. A 9-year-old child presents with nasal discharge. On performing anterior endoscopy, that means to examine the nose, there is single soft glistening mass visible. So what is the most probable cause? We can see in the picture here. There is a single soft glistening mass visible in the picture here. So we have got options: endoconal polyp, ethmoidal polyp, inverted papilloma, or the juvenile angiofibroma. So endoconal polyp is a very typical example of a single soft glistening mass that is visible in the nasal cavity. Usually ethmoidal polyps are usually multiple in number. Inverted papilloma is not common in children, and its appearance is usually polypoidal or lobulated. And as for the juvenile angiofibroma, it is usually seen in the young male, adolescent male, and it usually presents as a epistaxis, and the mass is not single soft glistening mass. It is usually pinkish and reddish fleshy mass. So we can easily rule out these two, and because of the number, single or multiple, this can easily be ruled out. So answer is A. So now we can see in the chart here, this is a very common question, the difference between endoconal and polyp and the ethmoidal polyp. Usually age group is young in case of endoconal polyp. Usually the age group is elderly in case of ethmoidal polyp. Usually infective cause is there in AC polyp. Usually allergic cause is there in ethmoidal polyp. Similarly, endoconal polyp is single, ethmoidal is usually multiple. Usually unilateral AC polyp, bilateral is ethmoidal polyp. Similarly, maxillary sinus is the site of origin for the endoconal polyp, and ethmoidal sinuses are the site of origin for the ethmoidal polyp. And similarly, it is large, globular, trifoliate or dumbbell shape. Similarly, small and grape-like lesions in the ethmoidal polyps. Now the question number 9. A patient with high-grade fever and malaise has pain in throat and muffled voice. There is collection of pus in between the capsule of tonsil and superior constrictor muscle. Which type of abscess is formed in this patient? So in such kind of question, the other hints in the question can be, sometimes examiner keeps the terms such as the deviation of the uvula to the opposite side, displaced and inflamed tonsillar pillar. Such kind of hints can be given in the question as well. So this is the question about the anatomy of various deep neck spaces of the neck. So the options are parapharyngeal spaces, retropharyngeal abscess, pretonsillar abscess, Ludwig's angina. Now we can see the anatomy out here. So the question says the capsule of tonsil and the superior constrictor muscles. We can see in the picture here. So this is the tonsil So this is tonsil, and this is the supraconstrictor muscle. So the space in between them is called peritonsil space, or in this case the abscess is peritonsillar abscess. This is the answer. So usually this parapharyngeal abscess is usually found posterior to the supraconstrictor muscles. So the answer is not correct here. Retropharyngeal abscess is usually found posterior to the buccopharyngeal fascia, and this is extended up to the superior mediastinum. So this is not the answer. And as we can see in the picture here, Ludwig angina is usually seen in the submandibular space, which is further divided into sublingual space and submaxillary spaces. So other questions that can be made out of this question are the description of the various extension of the abscesses, such as this danger abscess can extend up to the diaphragm, and this prevertebral fascia or the abscess can be extended up to the coccyx bone. So this question is trying to check your knowledge about anatomy of the deep neck spaces and abscess. Now the question number 10. A patient presented with a swelling on the parotid region. On examination was found to have medially displaced tonsil due to enlargement of the gland. On FNAC, mass was found to be pleomorphic adenoma. What is the management of choice in this case? So there are 4 options: adequate parotidectomy, total parotidectomy, chemoradiation, and partial parotidectomy. So in such kind of pleomorphic adenoma, usually the surgery is the choice. So that means the C is already ruled out. We have got options about either A, B, or D. Now let's see the another slide. Now here, so now we have to choose between the 3 surgical method. Usually this adequate and the partial parotidectomy is usually done in the case of small lesions, usually in the superficial lobe. As the description says, the swelling is seen in the parotid region, and also it is causing the medial displacement of the tonsil. That means the tumor is involving both the superficial and deep lobe, and the tumor is huge. So to access this deep lobe, we have to do the total parotidectomy. So the answer is B. As we can see in the picture here, facial nerve goes through the parotid gland, and the portion of the parotid gland that lies lateral to the facial nerve is called the superficial lobe, and deeper to the nerve is called the deeper lobe. And as the tumor is involving both the superficial and the deep lobe, we have to take out both of this lobe to gain access to the deeper portion of the lobe. Rarely, if there is a small tumor present in the deep lobe, rarely adequate parotidectomy is done, but normally this adequate and the partial parotidectomy is usually conserved for the small lesion present in the superficial lobe. Thank you. Wish you best wishes for your exam.